small component of leukemia, lymphoma, both GI lymphoma and lymph node and other relevant to a surgical student. So I have requested the head, Dr. Mallikarjun, who is a fantastic hematologist, hemato-oncologist, and stem cell and bone marrow head at Manipal Comprehensive Group. Excellent, academician, very great knowledge. In spite of his busy schedule, he has divided this talk into these 4-5 components. These topics are so huge, each in itself is a oration. Only benign hematology is like you can speak for 2 hours, then leukemias for 2 hours, then lymphoma 2 hours, stem cell. But I requested him, surgeon's knowledge is not as good as yours. So please speak, condense it for our students for basic knowledge. And as per your request, this talk is posted today. So please utilize it to fullest. At the end of his talk, if any doubts you have, anything you want to clarify, please put it in chat box or Q&A section and he'll try to answer in the given time. Thank you very much, Mallikarjun, and over to you.
Thank you, Somashekar sir. You're always an inspiration. You are our chairman and inspiration for all of work we do. So you are absolutely right. I'll try and run through my slides. There are lots of topics to cover, and hopefully we will have some time in the end to discuss about relevant topics. So I'll start with the common problems first, and then we'll cover a few slides of anemia, thrombocytopenia, bleeding disorders, something about cancer-associated thrombosis, a few essentially basic slides on classification of malignancies, a few slides on transplantation. I don't think we'll have enough time for recent advances, but we'll stop there. So anemia, we know, is one of the most common problem. WHO has changed the definition of anemia over the period of time, but anyway, with hemoglobin less than 12 to 13 is somebody who has anemia. So I think for a surgical student, it is important to kind of look at anemia more so in elective surgeries, wherein you have time to kind of do the course correction. And whenever a patient comes to us with anemia, we want to try and understand based on basic history as to what is the cause. Is it because of dietary deficiency? Is it because of blood loss? Is it a drug-induced one? Or is this associated with more serious underlying illnesses like a marrow failure, Myelodysplastic Syndrome, aplastic anemia, chronic liver disease, chronic kidney disease? So all of this can be easily diagnosed if one pays a little attention. Iron deficiency anemia is something which is extremely prevalent, even in developed countries, but more so in developing countries. And half of our population would be having some kind of iron deficiency. All of us during undergraduation have learned about the iron balance, that how body and the gut kind of optimizes iron absorption based on whether our body is iron replete or iron deficient. And that depends on multiple complex mechanisms that I don't think we need to really debate on. But what is important to know is when we do the oral administration of iron, even if you take, for example, 100 milligram, only 1 to 10% of that is absorbed. And the percentage of absorption of iron depends on how replete the iron stores are. And who plays a central role in iron absorption? That is hepcidin, and it does so by actually orchestrating or controlling the intestinal absorption, recycling by the macrophages, release of the iron store, and placental transport. And the common manifestations of anemia are same, but then a few things which are very, very typical for iron deficiency are pica, restless leg syndrome. We have had patients who've had such bad restless leg syndrome, they would be sleepless for several months. And the moment you give them the first dose of iron, they have a dramatic response. So pallor, angular cheilitis, platinacea are common manifestations of iron deficiency. Diagnosing it is extremely simple, and all we have to do is pay attention to the common tests that we do. I'm sure most of our patients have a complete blood count and red cell indices, and one need to look at those more closely. And if you see peripheral smear, there is anisocytosis, poikilocytosis, microcytosis. And one can look at the iron store simply by asking for the iron store, serum iron, transferrin saturation, ferritin, and transferrin receptor. And a ferritin less than 15 to 20 is indeed confirmatory of iron deficient stores. A ferritin less than 13 pregnant women is suggestive of iron deficiency, and transferrin saturation less than 15 to 20% is suggestive of severe iron deficiency. So what one also should be mindful is some patients may just have an iron deficient state without anemia, but that still needs to be corrected. Otherwise, one, they will develop over iron deficiency, and second, they would already be suffering from the symptoms of iron deficiency. Treatment is fairly simple. For several years, we've always been using oral iron. The advantage of oral iron, it's simple. The risk of severe adverse event is much less. The disadvantages being compliance is very poor, GI intolerance, constipation, dyspeptic symptoms, black stools. Those are the things which make patient very difficult to take it for a long time. Blood transfusion is only used in extreme situations. Remember, blood transfusion doesn't depend only on the absolute hemoglobin level. There are patients of iron deficiency who would walk to OPD with 4 to 5 grams. Perhaps they don't need blood transfusion, but then there are patients who are elderly, who have comorbid illnesses, whose hemoglobin, though is 8 to 9, might have anemic symptoms. So blood transfusion should depend on symptoms of anemia and not just the absolute value of hemoglobin. Now, intravenous iron is something which has come up in a big way for more than one reason. And few advantages being it is effective for most patients. There's a rapid correction of iron deficient stores, and one can do what is called a TDI, total dose infusion. A large dose of 2000 milligram can be infused, and compliance is assured. But disadvantage is it must be done in a hospital setup. It must be done under close follow-up, and also make sure that one doesn't have drug allergies, one doesn't have connective tissue disorders, one doesn't have allergies to other medicine, in which case one, it may need closer monitoring. Second, pre-medications with steroids might be needed. So we all always worry about how to calculate the various ways, but simple way to remember is anyone whose hemoglobin is less than 10 may need about 2 grams. I'm talking about adults. And anyone whose hemoglobin is more than 10 might need about 1500 milligram. So there are various IV iron stores. Again, I'm not going to go in detail, but again, the one that we commonly use is ferric carboxymaltose, which has got iron core and carbohydrate outer layer, and that is a simple one and can be used for a total dose infusion. B12 and folate deficiency causing megaloblastic anemia is another common cause, and we all have read about this. So the typical smear picture is one of macrocytes, macrovalocytes, hypersegmented neutrophils, and can occur after various clinical setting. Again, atrophic glossitis, knuckle pigmentation are common clinical manifestations. And if you see the smear here, you can see hypersegmented neutrophils, ovelocytes, and macrovalocytes, which confirm the B12 deficiency. So one can do measurement of vitamin B12, measurement of folic acid, but the old school, some of these patients may come to us with severe pancytopenia, thrombocytopenia. And when you do a bone marrow to rule out more sinister bone marrow disorder, what you see is a megaloblastic marrow, which confirms. So there are fallacies of B12 level and folate level, so I wouldn't debate again. So simple treatment is very simple. In fact, it's so simple that oftentimes there are patients wherein you can't do those levels, and you can just give them the therapeutic trial of 1000 microgram of vitamin B12, perhaps 5 to 7 doses followed by once weekly. And if it is indeed megaloblastic anemia, one sees very dramatic clinical and laboratory improvement with treatment. So I guess we'll spend some time about perioperative management of anemia, and that is very important. So we all know every transfusion comes with its own inherent risk, and all of us must do everything that is possible to prevent a transfusion requirement pre and perioperatively. And one can do that by one careful look at the reports of the patient before, making sure that we try and use corrective measures for the anemia, and see if patient is iron deplete, whether patient has B12 deficiency, whether he has other comorbid illnesses like anemia of chronic kidney disease, wherein one can use liberal doses of erythropoietin, darbepoetin to make sure we improve the hemoglobin preoperatively, so that the requirement of transfusions is much less. So this can again be a simple algorithm. Anyone with low iron must be given iron infusions. Perhaps parental iron is better way of replacing iron in this situation, and then use folic acid, vitamin B12, and erythropoietin based on other indices and comorbidities. So this way, we may be able to reduce the requirement of transfusions in these patients. So I think so the important thing to know in anemia is try and look at the red cell indices, try and look at the simple tests like complete blood count and peripheral smear more closely. And if you have time, and if a patient is undergoing elective surgery, try and correct the anemia before he gets to surgery. A few slides about thrombocytopenia. I'm sure all of us know about Dr. James Hober, who wrote about megakaryocytosis initially. Thrombocytopenia is simply defined as platelet count less than the normal range. It can be mild, moderate, or severe. And many times we see that the thrombocytopenia is detected just before the preoperative evaluation that the patient does. So whenever there is thrombocytopenia, please remember, one can just be a simple pseudo-thrombocytopenia, or it can be a more serious disorder of deficient platelet production, accelerated platelet destruction, or abnormal pooling like that happens in chronic liver disease with portal hypertension. So whenever there is a thrombocytopenia, first thing we must know that we make sure that this is not a pseudothrombocytopenia. And there have been many instances in real world wherein patients are given platelet transfusion, given high dose steroids, only to realize that this was just a pseudothrombocytopenia. And how does one diagnose that? A simple peripheral smear would tell you that there are a lot of platelet clumping and that the machine reading is just a false reading. So if there is a pseudothrombocytopenia, one doesn't have to do anything, and it can easily be diagnosed by careful attention as to how the sample was sent, was the sample collection not proper, and whether or not there are platelet aggregations on the peripheral smear. So that is step number one in any newly diagnosed thrombocytopenia that you come across. Now, decreased platelet production is always secondary to more serious disorders, marrow-failure syndromes like Myelodysplastic Syndrome, aplastic anemia, myelofibrosis or infiltrative disorders, hematological malignancies, and of course, hereditary thrombocytopenia like Glanzmann's thrombocytopenia, wherein it is not just mild thrombocytopenia, but also platelet function defects, which need to be diagnosed. Now, incomplete platelet restriction most commonly occurs with autoimmune conditions like ITP, which could be primary or idiopathic, or it can be secondary to any of the connective tissue disorder. It can also occur in non-immune processes, and these are more serious disorders like thrombotic microangiopathies, TTP, and HUS, wherein diagnosis can be a little tricky, and one has to look at more things like serum LDH, Adams 13 level, look at the Coombs test, make sure there is no overt coagulopathy before labeling people with thrombotic thrombocytopenic purpura. And it is important to recognize and diagnose this condition because if we don't treat that with plasma exchange and rituximab and steroids, patient might become too sick too soon. Chronic infections of malaria, dengue, and leptospirosis. We have had so many patients who come to us with thrombocytopenia, and then when you do a basic screening, many of them turn to be either chronic hepatitis C or retroviral infections. Few slides about ITP. One of the common cause of isolated thrombocytopenia. Typically, despite platelet count being low, patients are indeed very stable. It is a diagnosis of exclusion, and it can be classified as acute, persistent, and chronic ITP based on the duration. And we know the pathophysiology. Essentially, what happens here is the antibody-coated platelets are engulfed by macrophages, oftentimes in the spleen, and hence one of the things that we used to do for several years before was splenectomy for patients with refractory ITP. Diagnosis is fairly simple, but one must remember it's a diagnosis of exclusion. There is no signature abnormality either in the marrow or laboratory anomalies which tells you this is ITP. One must make sure that we rule out other causes for thrombocytopenia. So simple peripheral smear, infection screening, and based on the patient's clinical history, one may order other tests like an ANA or an RF factor or a C3C4 level or a thyroid function test or a H. pylori testing for a refractory thrombocytopenia based on the history. And if one were to do a bone marrow actually shows hypercellular marrow with adequate or megakaryocytosis, which tells us that the bone marrow is actually producing more platelets, but they are being destroyed in the peripheral circulation. So there are various ways of treating it, but again, we only treat patients who have bleeding symptoms or whose platelet count is less than 30,000. If the patient doesn't need a surgery, or if the platelet count is more than 30, such patient does not need any treatment. And again, there are various ways of treating it. When you try and increase the platelet production, and the commonly used agents are thrombopoietin analogs in this, and then you try and reduce the antibody-mediated destruction, and commonly we use steroids, splenectomy, rituximab, intravenous immunoglobulin for this. So the treatment of ITP has had a paradigm shift. So previously we would do a splenectomy in more patients. We would try and use rituximab and thrombopoietin analogs for the post-splenectomy relapse. We don't do that anymore. We try and push the splenectomy for the end, and then try and use all other medications early in the course of treatment of ITP. A quick drug check is extremely important when we're dealing with thrombocytopenia. Almost every drug can cause thrombocytopenia, but some common ones which are known to cause drug-induced immune thrombocytopenia or rifampicin, common antibiotics like piperacillin tazobactam, linezolid, sulfonamides, those are the agents, and anti-epileptic medications. So if there is a history of any of these medications, and if there is a temporal profile relation between the drug usage and thrombocytopenia, one must look at these. So sometimes it can be perplexing. All thrombocytopenias, they look same, but by careful history taking, looking at the vital clues during the physical examination, ordering relevant investigations, and perhaps seeking help at the right time, one could come to a diagnosis sooner, so that treatment of the patient becomes simple and surgery goes away smoothly. So, for example, if you see this a simple case of an elderly gentleman came with chronic back pain, the hematology consult was sought for mild thrombocytopenia. And when we looked at the smear, what you can see is increased role of formation and increased background staining. And a simple SPAP showed us that there was a lot of paraprotein, almost 6 grams. And then when we did the bone marrow, that in fact confirmed that the marrow was replaced with plasma cells, confirming the diagnosis of multiple myeloma. Another 58-year-old man came with fatigue, weakness, and pain abdomen, and he had pallor and massive splenomegaly. Again, smear, if you see, if there is a left shift, there is myelocyte, metamyelocyte, and promyelocyte. There are a lot of nucleated red cells. And when we did the bone marrow, there was extensive fibrosis on reticulin staining, confirming the diagnosis of myelofibrosis. So, bone marrow examination must be confirmed, must be used to confirm the diagnosis in elderly patients who have pancytopenia, who have massive splenomegaly, or even palpable lymphadenopathy, atypical cells on the peripheral smear, and organomegaly. So that is something important so that we don't miss a sinister problem causing cytopenia. There's another young fellow who came to us with PTK, pain in the gums, loss of weight and appetite. Clinical exhaustion showed severe pallor, bone tenderness, and if you see the hemogram, there is pancytopenia, right? And the marrow confirmed diagnosis of acute myeloid leukemia. So we always have to look at the simple test more closely to make sure that we don't miss a sinister problem. So this is something that we all have to remember, a paradox of thrombocytopenia, wherein patients typically have bleeding manifestations, but oftentimes patients may present with both thrombocytopenia and thrombosis. And the clinical conditions that one must be wary of is one, heparin-induced thrombocytopenia in a hospitalized patient or a patient who's shifted from ICU because they're likely to have heparin exposure, antiphospholipid antibody syndrome, and it can be a catastrophic APLA2. DIC is something which can happen peri-procedure in the hospital setting. TTP, HES, and PNH rarely are something that needs to be considered. So just to make that point, this is another 46-year-old man admitted post-RT, underwent orthopedic surgery. He was given heparin rightly for thromboprophylaxis, and the hematology consult was sought by the end of the week for thrombocytopenia. And if you see wherever the heparin was given, there was a red rash, and we know what happens in HIT. So there are antibodies which form against the complex of platelet factor 4 and heparin, and that leads to significant thrombocytopenia and thrombosis. And we also know that this can be a classical hit, wherein it typically occurs between day 4 to day 14, or it can be an accelerated or rapid onset hit, wherein the patient has pre-exposure to heparin and has a preformed antibody. And rarely it can also be a delayed hit. So that is something that needs to be remembered. And it's a very simple 4T clinical scoring that we can use to suspect the probability of hit, and then we can actually do a test called as HIT serology to confirm the same. And how do we deal with it? We must stop exposure of the patient to all forms of heparin, both unfractionated and low molecular heparin. And we will have to use non-heparin agents like argatroban, danapride, and fondaparinux, which is easily available in our country. Platelet transfusions must be avoided. So people always ask us, when should we consider transfusing platelets for thrombocytopenia? One, prophylactic transfusions may not be needed in all patients. Patients with severe thrombocytopenia, there is some data to suggest when the platelet count is less than 10,000, there is a risk of spontaneous bleeding. So obviously, severe thrombocytopenia, we must. And if the patient has active bleeding or has high-grade fever or has a lot of tubes inside, so the threshold should be a little higher. Now, if the platelet count is more than 50,000, most of the minor procedures and surgeries can be done. And for a general surgery or extensive oncologic surgery, neurosurgery, we try and maintain platelet count more than 100,000. So a few slides about bleeding disorders preoperatively, extremely important. And we quickly go through what happens in hemostasis essentially. So we all know as soon as there is a vascular injury, the response of the body is one, the vasoconstriction, platelet aggregation and platelet plug formation, and activation of coagulation cascade. And endothelial injury leads to the first phase of vasoconstriction and platelet plug formation. And the propagation of the clot is by the coagulation cascade. I'm not going to go in detail, but all of us have read about intrinsic pathway, extrinsic pathway, common pathway. There is some revision of the same, again, may not be very important. So we also know once the clot is formed, there is then termination of the clotting by antithrombotic mechanism, and that happens by fibrinolysis. So It is also becoming increasingly evident that thrombin is at the center of both coagulation and fibrinolytic pathway, and this precarious balance between the procoagulant and anticoagulant system is one which maintains the hemostasis in the body. So history taking is extremely important for any bleeding disorder, and simple questions like, have you had excessive gum bleeding? Do you have frequent nosebleeds? Have you ever had a spontaneous hemarthrosis? Do you ever had a spontaneous, melena or bleeding in the stool? Women with bleeding disorders like von Willebrand disease may have just puberty menorrhagia. So asking basic questions is what gives us, answers. Have they ever received a coagulation factor? Have they had platelet or plasma transfusion? So these are the questions that one needs to ask. Are the patients on blood thinner or antiplatelet agents? Simply when you ask them, they might then know that it is relevant and then tell you. And sometimes those need to be reversed before. So we also know that there are basic clinical history-wise and finding-wise difference between platelet disorders and factor deficiencies. Most patients either have thrombocytopenia or platelet function disorders, have superficial skin and mucocutaneous bleeding like petechial ecchymosis. They rarely ever have a spontaneous joint bleeding, whereas coagulation factor deficiencies like hemophilia have more deep situated bleeding like psoas hematoma or large hemarthrosis. Oftentimes they also have a target joint leading to morbidity and restriction of movement. So that is important to consider in the history taking. So when we do the laboratory testing, again, what test we need to order for bleeding disorder depends on what we have unearthed in the history taking. For example, if it's a young person who has absolutely no family history, nothing to suggest bleeding disorder, has never had any spontaneous bleeding, has never received transfusion, in him we may not need more tests really. And even if some of those basic screening tests are abnormal, I would worry about whether it was a laboratory error than having a serious bleeding disorder. So history and examination is extremely important. And oftentimes, if there is a suspicion of any bleeding disorder, severe or non-severe, then we start with basic evaluation of a complete blood count, looking at the morphology on the peripheral smear, looking at PT, APTT, serum fibrinogen initially, making sure there is no significant, uremia or liver disease. So if you have a prolonged PT, this is something that students always ask us, how do we make sense of basic screening tests? So isolated PT, abnormality, normal APTT, we typically look at the factor 7 level. It can also occur in vitamin K deficiency, liver disease, patients who are on warfarin, and of course, DIC can cause all kinds of hemostatic abnormalities. Prolonged APTT but normal PT is common in patients who have hemophilia A, B, or C, that is factor 7, 9, 11, a deficiency of factor 12, prekallikrein, and HME kininogen. So this is something that one needs to know. So when there is deficiency of these factors, the APTT is significantly prolonged, but there is absolutely no bleeding history. So that is something which needs to be understood. And oftentimes, even for surgeries, no course correction is needed if it is deficiency of these factors. BWD is something that needs to be considered in these patients because they can have additional factors and deficiency, and there are various acquired medical causes wherein this can happen. So both PT and APTT prolonged, this is more likely to be a combined deficiency of factors or afibrinogenemia, but it is also likely to occur in DIC, in patients who are on direct oral anticoagulants, and very ill patient who's got amyloidosis and factor 10 deficiency. So another thing is sometimes patient may have all of those screening tests being absolutely normal, and yet they may have bleeding disorder, and that is likely to occur in hemophilia, von Willebrand disease, factor 13 deficiencies, platelet function disorders, and alpha-2 antiplasmin deficiency. So these are the situations wherein patients may have significant bleeding disorder, but the screening test is absolutely normal. A few slides on DIC. We know it's a systemic process, and we know that DIC can lead to both bleeding and vascular thrombosis, and it can occur in almost 1% of admissions in most of the tertiary care hospitals, and all of you have seen DIC in the clinic, right? So, and most common causes being the 30% is because of malignancy, and obstetric reasons account for 15 to 20%, but sepsis and DIC secondary to a bad infection is much more common, both in pre and post-op situations. And DIC, the laboratory anomalies would depend on whether we try and diagnose it early on, or when the patient is extremely sick and has extremely hypocoagulable, and that is how the laboratory anomalies can be. So acute and chronic DIC need to be kind of distinguished, because the risk of bleeding is much more in decompensated DIC as against compensated chronic DIC, wherein some patients may actually be at risk for thrombosis. So that is something that we need to remember. Any difficult case can be sent to Goswami. He seems to know everything about everyone. So when you talk about DIC, and again, diagnosing is very simple. You do a complete blood count, do a coagulation screen, D-dimer levels are extremely high, make sure you're not missing a significant liver and kidney dysfunction. And there is no single lab test. You always look at the clinical background and then look at the laboratory test and then try and diagnose DIC. How do you treat? Extremely important that we must treat the underlying cause. Process of thrombin generation, fibrinolysis has to be reversed, and the stimulus for the DIC has to be taken out. And supportive measures, one is hemodynamic and ventilatory support, very important. Aggressive hydration, strict intake output monitoring, and transfusion support. So we always must remember that there is no role for prophylactic transfusion. You are never trying to correct the laboratory anomaly in these patients, and we only use transfusion if the patient has bleeding or if the patient needs any surgical intervention. And no need to transfuse for all thrombocytopenias. Transfuse only if there is serious bleeding or if the patient needs surgery and platelet count is very low and platelet less than 10,000 in extremely sick patients, one must. And again, people ask us which is better. Single donor platelet is always better compared to pooled platelets or random donor platelet. And patients who have bleeding symptom and have overt coagulopathy with prolonged PTA, PTT, or hypofibrinogenemia would need correction with fresh frozen plasma or cryoprecipitate, depending on the clinical setup. So the goal is to reduce bleeding and not to normalize coagulation tests. That is something that needs to be remembered in treatment of DIC. And we can't just keep giving them blood without reason, because that might actually worsen the DIC. Anticoagulant reversal is important because sometimes you get a patient who needs surgery and then has been on blood thinner. So I'll just briefly tell you, if the patient is on warfarin, you use vitamin K, prothrombin complex concentrate, FFP, or a recombinant factor 7, depending on how soon you want to reverse it. For a low molecular heparin and unfractionated heparin, use a protamine sulfate. And for newer anticoagulants, again, prothrombin complex concentrate can be used. If somebody has been on dabigatran and comes to us with intracranial hemorrhage or acute bleeding, adalimumab is something which is available, and that's an antidote for dabigatran. So massive transfusion, people will always ask you. There have been various definitions, but massive transfusion essentially means you try and give them equal ratios of FFP, platelet, and RBC to reduce the risk of dilutional thrombocytopenia. So 3 most important tests for bleeding disorders. My boss would always make this slide. So it is history and history and history, and not any other special test really. Few slides on cancer-associated thrombosis. So we know that individuals of cancer have a higher risk of having a vascular thrombotic event as against normal individuals. It can be seen in almost 10% of patients of cancer. And it could be because of various things, but commonly acknowledged factors being the tumor-specific factors, anatomical locations of the cancer, patient-specific factors, past history of thrombotic events, and of course, treatment-wise, for example, a patient of multiple myeloma who's on lenalidomide, dexamethasone, and bortezomib might be at a higher risk of thrombosis because of the treatment itself. So we know that not all cancers have equal risk of thrombosis, and even among surgical patients, some of these cancers have higher risk of cancer-associated thrombosis than others. And when there is a patient of cancer in the hospital, depending on the risk of thrombosis, one must try and make sure that they are on thromboprophylaxis. So all hospitalized patients with malignancy, reduced mobility, who do not have risk of increased bleeding, must be on pharmacological thromboprophylaxis. And the most commonly used agent is enoxaparin 40 milligram Q24H. And patients who are undergoing cancer surgery, perioperative VT prophylaxis is extremely important. And anticoagulation of patients of thrombosis, of cancer who need surgery, even if the platelet count is more than 50,000, that should be good enough for us to initiate thromboprophylaxis. Various agents have been used, but there is enough data to suggest that enoxaparin 40 milligram once a day is perhaps safer and convenient as against other agents. If there is any concern of heparin-induced thrombocytopenia in the past, then you would want to use fondaparinux instead of heparin. So people always ask us, is there a need for giving outpatient primary thromboprophylaxis for patients of cancer? We don't do that in everyone. There are various scoring systems. Corona score is one of the scoring system that is used. You can go through that, and if the patient has a very high risk based on the scoring, then maybe under extraordinary situations one can consider primary thromboprophylaxis as an outpatient. But largely the conventional wisdom is primary prophylaxis is not recommended for most outpatients of cancer who's not had any history of vascular event. So whereas patients who have an established thrombosis with active cancer, we must treat them with therapeutic doses of anticoagulation. And here one can use low molecular heparin, which is preferred based on the data. But if the patient wants an oral-based treatment, then apixaban and rivaroxaban are the other alternatives. Just to remember, rivaroxaban in patients of GI malignancies is better avoided because the risk of significant bleeding is higher as against other ones. Apixaban is something that can be used. But if the patients have significant renal dysfunction, then one may have to go back to unfractionated heparin. So one is the acute treatment of thrombotic event and how long to continue the anticoagulation. So most of the times we at least continue the anticoagulation for 3 to 6 months. But if the patient continues to have active cancer, impaired mobility, they continue to be at a higher risk of thrombosis, and such patients need to be continued on anticoagulation longer. Now, in a rare situation wherein patient has a very bad thrombus and with increased clot burden, but may not be fit for anticoagulation because of various reasons, significant bleeding, very significant thrombocytopenia, in such patients, one may have to consider about IVC filter placement. So a few slides of hematological malignancies. We know there have been various classifications, but we largely divide those cancers into mature B-cell neoplasm, T and NK cell neoplasm, Hodgkin's and non-Hodgkin's lymphoma, and post-transplant lymphoproliferative disorder. We also have various Myelot malignancies, myeloproliferative neoplasms, mastocytosis, Myelodysplastic and overlap syndromes, the acute myeloid leukemia and related disorders. And those are the ambiguous lineage and B lymphoblastic leukemia, T lymphoblastic leukemia, the common ones. So essentially, when we talk of hematological malignancies, the common ones that we come across is multiple myeloma, accounting for about 10% of malignancies. Acute leukemias, when we talk about acute leukemias, it is acute lymphoblastic leukemia, acute myeloid leukemia, and rarely mixed phenotypic leukemia, which accounts for a few cases of acute leukemia. How do we diagnose acute leukemias? Individual who has more than 20% blast either in the peripheral circulation or bone marrow is deemed to have acute leukemia. There are few exceptions to that, but that is something that one needs to remember. In terms of myeloproliferative neoplasm, we divide them into classical and non-classical, and all myeloproliferative neoplasms largely are divided into Philadelphia positive and Philadelphia negative. And that is by a simple test wherein you look for a BCR-ABL translocation. Myeloproliferative disorders which are BCR-ABL positive are categorized as chronic myeloid leukemia, and those are treated distinctly with tyrosine kinase inhibitor, whereas the other myeloproliferative neoplasms, which are Philadelphia negative, classically are essential thrombocythemia, polycythemia, primary myelofibrosis, and systemic mastocytosis, and the treatment of those disorders is different. And perhaps the outcomes of Philadelphia positive chronic myeloid leukemia is much better now because we have targeted therapy with tyrosine kinase inhibitors like imatinib, nilotinib, dasatinib, and ponatinib. Myelodysplastic syndrome is a low-grade malignancy of the bone marrow, and the incidence and prevalence of myelodysplastic syndrome increases as one grows older. And the disease itself is very heterogeneous. At one end of the spectrum is just refractory anemia, and the other end is myelodysplastic syndrome with excess blast, which is akin to acute myeloid leukemia for therapeutic classification, really. So that is the myeloid neoplasms. Whereas lymphoid neoplasms, we know largely we have commonly acute lymphoblastic leukemia. And then we have B-cell neoplasms, Hodgkin's and non-Hodgkin's lymphoma. Hodgkin's lymphoma is again divided into classical and lymphocyte predominant. And non-Hodgkin's lymphoma has largely been divided into B-cell and T-cell phenotype. And the common ones are the diffuse large B-cell lymphoma and follicular lymphoma. So all of these are again heterogeneous baskets, and Most of diffuse large B-cell lymphomas are CD20 positive. This is one of the largest subgroup of non-Hodgkin's lymphoma. And then we divide them based on the cell of origin into GCB, germinal center diffuse large B-cell lymphoma, non-GCB, non-germinal center diffuse large B-cell lymphoma, and then ABC or activated B-cell type diffuse large B-cell lymphoma. Conventionally, for several years, the DLBCL was treated with CHOP therapy. Now we have various immunotherapy modalities which are available, but the most common one that has always been used is an anti-CD20 monoclonal antibody called as rituximab. So widely used chemoimmunotherapy protocol for the diffuse large B-cell lymphoma is R-CHOP, combination of rituximab with CHOP, typically administered once in 3 weeks. And depending on the stage, if it's a localized disease, we try and do 2 to 4 cycles followed by radiation. And if it's advanced disease, we try and do 6 cycles. And some of these patients are also at a very high risk of having CNS involvement, so they need some kind of CNS directed therapy. So B-cell lymphomas, they do well as against T-cell lymphomas, simply because we have more immunotherapeutic modalities in B-cell lymphoma, and T-cell lymphoma tends to be more aggressive. So that is the difference. So I think we'll go through a few slides of bone marrow transplantation, and then I think we will take up the questions. So bone marrow transplant, I hope I'm not putting you guys to sleep. So bone marrow transplantation is also termed as blood and marrow transplantation and hematopoietic cell transplantation, more aptly called as hematopoietic stem cell transplantation, simply because we use multipotent hematopoietic stem cells to repopulate a diseased marrow here. So what is it essentially? It is transfer of stem cells with a repopulating capacity and the potential to sustain long-term hematopoiesis. If you take those stem cells from the same individual, we call that autologous transplantation. If you take it from another individual, you call it an allogenic transplantation. So sometimes all of us have learned lesson from great tragedies, and the bone marrow transplantation came to advent after realization that all of us are extremely radiosensitive, and then marrow can be ablated with radiation. So if you look at the immunotherapy modality, one of the first immunotherapy indeed is allogenic bone marrow transplantation, wherein you try and use the donor immune system to kind of destroy the bad cells in the recipient. And from all the way there, we have had various monoclonal antibodies, immunoconjugates, checkpoint inhibitors. Now we talk about what is called as chimeric antigen receptor T cell or CAR T cell, which is increasingly used in hematological malignancies. We all know who's the big B of Bollywood movie, but the big B of bone marrow transplantation is Sir Donnelly Thomas. He dedicated his life for advent of bone marrow transplantation and rightly was awarded a Nobel Prize for the same. So we know that stem cells are different from more differentiated cells because one, they can have a self-renewal. Stem cells can divide into more and more stem cells, or they can differentiate into organ systems. So stem cell is when you talk about bone marrow transplantation, what we use is multipotent hematopoietic stem cell transplantation. So before you transplant a patient, we have various evaluation to look at the disease status, the fitness of the patient, whether he can go through the transplant, and whether he is fit enough to undergo. So we divide transplantation into autologous transplantation, wherein we use patient's own stem cells. Commonly used diseases are multiple myeloma, relapsed refractory lymphoma, and some solid organ tumors. Whereas if the patient has a disease like acute leukemia or refractory lymphoma, one may have to then use allogenic bone marrow transplantation, wherein the stem cells are taken from a healthy donor. Cord cell transplants are not very widely used because of advent of haplotransplant. So in autologous transplantation, patient has a disease like myeloma, and then we treat that first and put the disease in remission. We collect the stem cells, we cryopreserve them, give them very high dose of conditioning chemotherapy with the idea of destroying the disease, but the chemotherapy used in such high dose that it would end up leading to ablation of the bone marrow, and then we reinfuse the collected cells, helping repopulate the bone marrow. The common diseases are multiple myeloma, non-Hodgkin's lymphoma, Hodgkin's lymphoma in relapsed refractory setting, Waldenstrom's macroglobulinemia, and a type of AML called as acute promyelocytic leukemia. Rarely we use an autograft for patients who have bad immune disorders like Crohn's and multiple sclerosis. When you talk about allogenic bone marrow transplantation, we always have to have a donor, and we know that all of us inherit our HLA haplotype from our parents. So just as it is important to do the blood group matching for blood transfusion, for allogenic bone marrow transplantation, it is indeed very important to look at the HLA more closely. And the best donors are HLA identical siblings. And if you see more siblings, more is the probability of HLA matching, because we inherit one HLA haplotype from father and one from mother. So if you look at this example, patient and sibling 3, they have inherited the exact HLA haplotype from father and mother. That is why sibling 3 is an HLA identical donor for patient 1. So with shrinking family size, less and less patients have HLA identical sibling, which is what is leading to increased use of partially matched or haplotransplants. So here what we do is a patient who has a disease, again, we try and treat and keep the disease into remission, and then give them conditioning therapy, collect the stem cells from the donor, and then infuse them to repopulate the bone marrow. Donor selection, apart from the HLA, you look at the blood group, you try and choose a younger donor. You see that if there is a gender match, you try and use that. You try and avoid a multiparous woman because of increased risk of HLA immunization and allo immunization rather. You also try and match CMV and EBV zero match. So in the absence of a mass sibling donor, which is what is happening in many instances, we try and use what is called as MUD, or a matched unrelated donor, haploidentical donor, or CORD as a last resort. Common indications for an allograft are AML, axillitoblast crisis of CML, MDS myelofibrosis, and relapsed refractory lymphoma. India and Asian subcontinent continue to have a significant proportion of hemoglobinopathy, thalassemia, and sickle cell disease, and they account for almost 30% of transplants in pediatric age group at least. So how do we do that? So the technique is, first you have to mobilize the stem cells, cryopreserve them, administer conditioning therapy, and then reinfuse. How do we collect? So previously all the stem cells were collected from the marrow, hence it was called as bone marrow transplantation. Now most of the stem cells are collected from the apheresis machine. All we do is use GCSF, mobilize stem cells, put them on the same machine wherein we collect these cells. This is Mr. Abdul, who helps us with our stem cell collection. So once we collect the cells, you do a CD34 enumeration to find out whether you have enough stem cells, and then you cryopreserve them at -80 or -160 and use them for reinfusion. We tend to do a marrow harvest when we have a thalassemia or a bone marrow failure. Typically, you take the donor to a OT, give him general anesthesia, and collect about 10 to 20 ml of bone marrow from the multiple punctures on the posterior iliac spine, and it is done in the OT. So stem cells can be kept in extremely low temperatures for a long time, and conditioning therapy is necessary to ablate the marrow and make space for the new cells. And stem cell infusion itself is to be done at least 24 hours after the completion of conditioning therapy, and it could be fresh cells or a cryopreserved cell. And stem cell reinfusion itself is fairly simple. It is like blood transfusion, and once that happens, once the stem cells go in, it may take about 2 to 3 weeks for them to repopulate the marrow, and what we call as engraftment, and that is when patient would be then fit for discharge. And in allogenic transplantation, we will have to use graft versus host disease prophylaxis with immunosuppression, so that there is no adverse effects of graft versus host disease. And once the transplant is done, we will have to monitor them to find out what we call as chimerism, so to see what percentage of cells are donor and what percentage are recipient, because one may have to play with the immunosuppression depending on the chimerism studies. And it is extremely important that the patient maintains a good donor chimerism. A falling chimerism could be early evidence of rejection and relapse of the disease. So there are various complications of transplant. Again, I'm not going to go in detail, but the significant ones are major mucositis, early infections, delayed infections, graft versus host disease, organ dysfunction, and delayed complications of the transplant. GVHD is a significant problem, and chronic and acute GVHDs are known. Acute GVHD typically affects the gut, the liver, the skin. The chronic GVHD can affect various organs, and again, we'll have to treat them based on the severity. People ask us, what is the mortality risk of transplant? With autologous transplantation, it's about 5%, and with allogenic transplantation, it is about 10 to 20%. And if you see, in India, we started transplanting sometime in late 80s, and the number of transplants have gone up exponentially. This is the data from Indian Stem Cell Transplantation Registry, and I'm sure the updated data shows that the transplants have indeed increased exponentially. And again, the common indications being about quarter of transplants are because of hemoglobinopathies, another quarter are for acute myeloid leukemia, whereas in autologous transplantation, almost half of them are for plasma cell dyscrasia, like multiple myeloma. So that is the indication for common autologous transplantations. So I think we are about 45 minutes now. So I will stop here and let us see if there are any questions. Maybe I'll have to stop sharing to look at the question.
Thanks, Mallikarjun. There are
Yes.
questions both in chat box and this. One is Yogesh Das. Sir, it may be silly question. There is no silly question. Don't worry. Everything, your questions are far superior than ours. When should we stop clopidogrel and ecospirin in
Yes,
cancer patient before we start a surgery? See, this is always there for surgeon.
Yes,
Now in cancer, most of our patients would have had a say, would have had a cardiac stent. They're on a clopidogrel or ecospirin, or they would have had a stroke, and so they would have been on these two blood thinners.
Yes.
Prior to make aspirin to be stopped, is it required? Yes, no. If yes, what dose?
Yes.
And when should we stop? What day?
Yes, sir. So this is I think the most important question. So when we talk about stopping anticoagulation, bridging anticoagulation, we look at two factors: the host factors and the surgeries. How bad was the thrombosis? Whether it was a recent clot, for example, somebody who's had a cardiac event within 12 weeks, we'll have to deal with them differently than somebody who had it 10 years before. So the simple question is, we need to stop clopidogrel aspirin at least 5 to 7 days. But sometimes simple answers are not true. So we will have to look at multiple things. If somebody has had a recent event, somebody has had a life-threatening event, then we do what is called as bridging anticoagulation. You try and stop the antiplatelet agents 5 to 7 days, 7 days before the procedure. Put them on an alternate anticoagulation like low molecular heparin, which can be interrupted before 12 to 24 hours of the surgery. What is also important to know is sometimes when you have to take the patient up immediately and when they're on antiplatelet agent, many times I have seen the surgical residents think that, sir, we'll just take the patient for surgery and we'll give them platelet transfusion and do the surgery. But be advised, when we do that, the circulating half-life of this antiplatelet agent is so much that even the transfused platelets would be blocked. So platelet transfusion is not a reversing thing for antiplatelet agent. So we will have to use the bridging anticoagulation if needed. Otherwise, we will have to interrupt them at least 5 to 7 days before procedure.
Thank you. INR is deranged before biopsy. You know this, we send them for CT guided lung biopsies, lymph node biopsies, abdominal biopsies.
Yes.
And the radio intervention radiologist always asks INR, and we find it deranged.
Yes.
So what is the guideline and protocol for vitamin K protocol before a biopsy?
Correct, sir. So vitamin, INR less than 1.3 is fairly safe for most of the procedures. INR more than 1.3 to 1.5, the risk of bleeding is high. Again, reversing INR, there are two ways. One, we do vitamin K. It may take about 12 to 48 hours for reversal. But the caveat being, once you use vitamin K, again using warfarin, it takes about 7 to 10 days for the coagulation to reoccur. So one is using vitamin K if you have enough time and the risk of thrombosis is less. Other one is using fresh frozen plasma, wherein you are not actually reversing it, and that might be simpler. And again, the INR reversal is fairly fast in that sense. So INR less than 1.3 is simple. We don't have to do anything. If INR is more than that, the risk of bleeding is high.
Okay, Nikunj has asked, what are the principal factors to decide between a Clexane and a Fragmin? You know, I told you, surgeon knowledge is very poor. For us, no, this, for pharma people will come and say, sir, Fragmin you use, very good, renal protective, don't use Clexane. Next, suddenly they say, come use Arixta, very good, long acting, no bleeding. Our knowledge is all through that because we don't open hematology. So Clexane, Fragmin, and Arixta, can you please let us know what surgeon know about these three?
Yes, sir. So one is low molecular heparin. Largely, the ones that we use are dalteparin, enoxaparin. That is Clexane, Fragmin. There is absolutely no head-to-head study to tell that one is superior to the other in terms of efficacy or risk of bleeding. But there is some sparse data to suggest that the Fragmin, the dalteparin, is perhaps little better when the renal dysfunction and creatinine clearance are less than 30. So that is one clinical scenario wherein you may use Fragmin or Clexane. That is dalteparin or enoxaparin. Now, when we talk about the therapeutic dosing, we always try and use 1 milligram per kg of enoxaparin or 100 international units per kg of dalteparin. Now, with regards to fondaparinux or Arixtra, we typically use it in patients who have any history of heparin-induced thrombocytopenia, patients who have had a past exposure and have had the vascular events, and there we try and use 2.5 to 5 milligram once in 24 hours. So in terms of efficacy, they're all same. For most cancer-associated thrombosis, low molecular heparin is preferred and an ideal agent. And for outpatient-based anticoagulation, one can use newer oral anticoagulants. The caveat being, again, you try and use apixaban, and there is some data to suggest increased risk of bleeding for GI malignancies with rivaroxaban. Principal factor to decide between Clexane and Fragnacer. I think we discussed that. Yeah.
Another one is, what is hematological effects of bevacizumab? Coagulation. Does it has an impact on coagulation?
We don't use it in hemato-oncology bevacizumab much. So we have not. I'm not very sure, sir. I'm not very sure whether it has any effect.
See, bevacizumab is a very big molecule. It is an anti-VEGF receptor. So its impact is not predominantly on coagulation and bleeding time alone. Most of these patients are anti-VEGF receptors. So there is a disruption of a micro blood vessels and they bleed. So it is not necessarily because it alters the clotting factor mechanism or a hematological mechanism. That's why the bevacizumab induced bleeding or anticipated bleeding, which happens in 2.3% spontaneously, and about 4 to 5% when there is a major surgery done in a patient who is on bevacizumab, not waiting for 6 weeks, cannot easily be corrected by any of this clotting factor transfer or hematological, because it is a anti-VEGF receptor. There is a disruption of the vessel, and unfortunately they would need some form of intervention or a embolism by intervention radiologist to occlude the blood vessel. That's why bevacizumab is a very big molecule. The half-life is 6 weeks at least. So the last dose of bevacizumab and a major GI surgery to prevent bleeding and perforation is 6 weeks. That's why you must be very careful if a patient is on bevacizumab, that 6 weeks. We normally wait only 2 to 3 weeks since last medical oncologist chemo intervention, but bevacizumab 6 weeks you have to wait. Yeah, thanks. And let me see what other questions are. Same question, same this one which you answered. Current guidelines to stop anticoagulant and antiplatelet before a major surgery. You already answered. I think if a patient is on a baby aspirin, it is not a contraindication. We don't have to stop it. Right? Only if they are on 150, you have to stop it.
Yes.
25 is okay. So 3 to 5 days is what you told, but bridging is what would be recommended rather than abruptly stopping or taking a patient with that.
Yes.
So there are some other questions. One of them is, what is the dose of vitamin K you have to give to correct all this?
So we typically do 1 to 5 milligram. Most of the times people end up using 10 milligram. That might lead to overcorrection. So 5 milligram is an optimal dose. Given as infusion is perhaps safer than giving it as an IV bolus.
Okay. Hari Prasad has written, sir, please mention the importance of IHC marker in.
Yes, yes. So immunohistochemistry is extremely important, more so. Sir, can you hear me? So immunohistochemistry, IHC markers are extremely important for diagnosing and classification of lymphomas. Oftentimes, based on morphology, it can be very tricky. And we also not only use it for classification, but also prognostication. Like I was mentioning, in diffuse large B-cell lymphoma, we use MUM1, we use FOX in Hodgkin's lymphoma. So we have to kind of delineate the cell of origin, which helps in diagnosing. So, for example, the B-cell markers are CD19, CD20, the T-cell markers like CD3 and CD7. We also have prognostic markers like proliferative index, like MIB index, which tells us about the proliferation of the disease, like in Burkitt's leukemia, lymphoma. So IHC is extremely important, not just for classification, but also on prognostication. And similar to IHC, immunohistochemistry is something called as flow cytometry that we use in acute leukemia to again classify patients into acute myeloid leukemia, acute lymphoblastic leukemia, and leukemias of mixed lineage. So there are scoring systems. These are essentially the surface antigens on the cell surface, and we use monoclonal antibodies to kind of classify these disorders.
Thank you. Thank you. Students, please listen to those markers he told to distinguish, because, when we give a lymph node biopsy or a ferrous meal, eternally there is a difficulty in subclassifying these lymphomas and leukemias. And the marker Mallikarjun told is something very important. Next thing is, good what is the cause of some cases of pancytopenia develop in CA rectum post-operatively, post-chemo radiation, how to manage? Before Mallikarjun takes up, I'll just tell you as a surgeon, remember when we have an adult patient, the two most important source of bone marrow is sternum and pelvic bone and sometimes rib bones. Basically, all other long bones get replaced by fat. But still, until last part of the age,
Sir, you're muted.
the sternum, iliac crest and ribs and pelvic bone have a significant marrow. And in case of rectum, we give 5040 centigrade to the rectum, which is almost from IMA up till the coccyx, where the entire sacral bone and the pelvic bone gets irradiated, whether you like it or not. So that's why most of the time there is a marrow loss, which itself can induce pancytopenia, which may never recover. We have seen, and they go to Myelodysplastic Syndrome or myeloproliferative disorders. So keep that also in mind, impact of radiation on a marrow of the whole pelvic bone. Now over to Mallikarjun. Am I right, or is there anything you want to add?
Absolutely. So that is the most important thing. So as we grow old, the axial skeleton remains the hematopoietic system, and other appendicular skeleton is no more producing the hematopoietic stem cells. So any radiation to the axial skeleton will lead to profound cytopenia. Now, like sir was mentioning, this can be transient, wherein you try and use growth factors like GCSF or thrombopoietin analog to accelerate the marrow recovery, but some of that can lead to aplasia or aplastic anemia. Now, we also look at what is called as therapy-related myelodysplastic syndrome and AML, that typically occurs after 2 to 3 years after alkylating agent or topoisomerase inhibitors, and it can be a very, very bad acute leukemia because treatment of this is extremely difficult. Curative treatments are not available, and oftentimes the only way to salvage them is by doing an allogenic bone marrow transplantation. So it could be transient cytopenia because of treatment, transient cytopenia because of radiation, or a bad secondary myelodysplastic syndrome or AML causing cytopenia. And sometimes it can also be a simple disorder. Somebody has had a bad surgery, nutritional deficiency, B12 and folic acid deficiency. So we must always do a systemic evaluation and try and do the course correction.
Thank you. Rakesh, it's an excellent question you asked that really helped everybody's discussion. Rakesh, Rishikesh has one question. Sir, what is the guideline for blood transfusion before and after surgery? I'll tell you, Mallikarjun, why this is. We have an evidence that in rectal cancer, colorectal surgery, if we do a blood transfusion, that has got overall survival, which is poor. Essentially, two reasons. One is blood transfusion induces immunosuppression after a colorectal surgery, and immunologically, there is a delay in the chemo given, so there is overall survival compromise. Second issue is blood transfusion during colorectal surgery suggests that the surgery was tough. We have breached the plane, we have gone in the wrong area, there may be advanced disease where they are adherent, and so we proceeded for blood loss, and then we gave blood transfusion, which are bad prognostic group of disease with a bad surgery. That's why overall survival in blood transfusion colorectal is poor. So we are afraid to give, and also blood transfusion increases viscosity. If we have done a microvascular flap and other, we are worried. Having said that, there is a scientific indication when anemia needs to be corrected before and after surgery. So when do you recommend blood transfusion in before and after surgery to correct anemia?
Yes, sir. No, so I think you have articulated it very well. So essentially, one, we don't look at the absolute number as a threshold of transfusion, number one. We always have to look at the comorbid conditions, age of the patient, whether it's a symptomatic anemia or not, what is the proposed surgery, what is the risk of bleeding in them. And again, you are absolutely right. The conventional wisdom is we must try and avoid a transfusion if we can, because it has both immediate effects like TACO, transfusion-associated circulatory overload, rally, which can cause respiratory distress and make the patient too sick for the surgery. So whatever we can do to prevent the transfusion must be done. And if it's an elective procedure, like we have discussed before, if it's iron deficiency, do the iron repletion, B12 deficiency, try and use it. And if it's a chronic disease and low EPO, try and use erythropoietin to improve the hemoglobin pre-procedure. That is one. Number two, in terms of threshold, again, anyone with hemoglobin less than 7 grams, we think needs transfusion before surgery. Oftentimes, your anesthesia colleagues may refuse to give anesthesia if the hemoglobin is less than 7. But if it's a young person with a very minor procedure and the risk of blood loss is minimal, perhaps even severe anemias can be managed without transfusion. Now, in terms of post-operative, again, we always think that post-operative replacement of so in fact there are studies wherein people just went ahead and gave 500,000 milligram of iron without looking at the iron stores, and they realized that the transfusion requirement of such patient was much less, and that they had better overall outcome as against people who received multiple transfusions.
Superb. It's a very good point, and I would request all of you to read volume 1 of Devita, and also General Surgery Sebiston, beautiful chapter on blood and blood product transfusion to be done, not done, what surgeon should know. Beautiful chapter. Also remember, students think that okay, 12 hemoglobin, 13 hemoglobin, 14, very good oxygenation. No, please read the oxygen dissociation curve in Genong's textbook of physiology. The best dissociation of oxygen and oxygenation happens between 8.5 and 9.2 hemoglobin. So don't think that 10, 11, 12, 15 is better. No, the best oxygen dissociation curve that happens is happening between 8.5 and 9.2. So sometime keeping that around 9.5 is better than giving 14, where the dissociation becomes less actually because of a higher hemoglobinopathy. So don't be under this. Please read this. As a surgeon, I used to read these two books to understand that too low is bad, too high is bad. Keeping it around 9.2 in your flap surgeries is the best oxygenation. As long as you oxygenate them well, that is the best oxygen dissociation curve in hemoglobin can give if you want. I think there are a lot of other questions. Same thing, sir. If we are doing a chemoport usage, anticoagulation therapy necessary, I'll answer it. Now it has been proved beyond doubt that when a patient is on chemoport, there is no required for specific anticoagulation. Like old time, putting them on aziptrom or Clexane because there is a chemoport. But however, follow the Bergami guidelines. Bergami is a place very close to Italy. Every 2 years, there is an annual conference of thromboprophylaxis required for oncology and other hematological condition. Fantastic conference. I attended several times. Whole 4 days is only about hematology and coagulation profile for everybody. The answer is the anticoagulation is based on the primary disease. Any malignancy patient based on the stage, localized or advanced, should be on 6 to 8 weeks of prophylaxis. And if a patient had any history of DVT or PE, then they go for 3 to 4 years. So the anticoagulation may be not per se because you put a chemoport to prevent it block. It's not going to help. It is for the primary disease. So it's not a bad idea that if you put a chemoport or a Hickman for a hematological condition, then to discuss with hematologist to give this. Or if you have a lung, colorectal with a systemic metastasis, say lung, liver metastasis, they're highly thrombogenic. They have a high viscous blood and HBS factor, various factors are all circulating down. They in general have a higher chance of pulmonary embolism, PE, DVT, and occlusion of the chemoport. So the Bergami guideline says those patients should be on roughly 4 to 6 weeks of Clexane. Mallikarjun, am I right? Anything else you want to add?
So we don't do primary thromboprophylaxis for port insertion. Sir does most of the ports. We don't do that. Not even port. In fact, even in PICC, PICC line insertion, we don't do thromboprophylaxis for those only. But if they have a catheter-associated thrombosis, or if it's an inpatient based on the risk of cancer-associated thrombosis, like sir was mentioning, we do the thromboprophylaxis, not just for the port or PICC line.
Thank you. Looking at the question, we can make out how important this is. That there are a million questions. I'm very happy I took the advice of my students who requested to have this talk. Mallikarjun, superb. Your knowledge is amazing. You're a sea of knowledge. And most important is your theory knowledge is applicable to the practical way you want to put it. Thank you very much for this.
Thank you for the opportunity, sir. Thank you.
Thank you very much. Over to you, Navneet Singh ji.
Thank you, sir.
Thank you very much, Dr. Mallikarjun, Kalashetty, for the presentation. And thank you very much, Professor Dr. Somashekhar, for joining us. And thank you, trainees, for joining.